don't have complications, you don't do enough cases. So that brings me to complications. So we all should have some complications, right?
Yes.
But we don't really like to talk about it. I need to, yeah. So very quickly, what is complications? Well, complication is any deviation from the ideal post-operative course that is not inherent to the procedure, but does not compromise a failure to cure. If you look one down, failure to cure is a condition that remains unchanged after surgery. So no matter what you do, you don't achieve your goal. And the sequela is something which you can't avoid, such like a scar formation after surgery. Now, you all have seen this, and I'm not going through the detail. There are many attempts to classify complications. The most used one is the Clavian complication. And this is an interesting slide showing what do urologists actually report, because we don't like to talk about complications, right? In the old days, we always presented our best cases and we kept quiet about the complications. Now you can see on the left side that there is a clear rise in the reporting of complications, and more people, that's the dark blue ones, they're using some sort of criteria. And if you look on the right, then you can see that the most applicable criteria are actually the Clavian complication, the Clavian grading scales. Now, if we come to PCNL, and I could talk about this 2 hours, it's only one slide. We have a minimally reversible renal damage of 0.15%. So this is an important thing to know when patients ask you, yeah, you're making a hole in my kidney, and are you not destroying part of my kidney? Now, the overall serious complications are in the range of 5 to 6%. And don't forget, PCNL is still, although it's minimally invasive, is probably the most invasive of the minimally invasive ones. It has still a death rate of 0.5%. Now, what about children? Is there any difference? Well, there's not, I can tell you that. Don't go through the details here. The only difference is children get less blood transfusions and have less hydrothorax. Otherwise, the complications are exactly the same, and the grades of complications are exactly the same. So, coming to a case, and can I kindly ask the audio, the panelists to unmute their microphones? Can we do that? Hello?
Yeah, we are doing that.
Yes, sir.
Professor Jivlet, yeah.
Okay, so I will invite you to be
Unmute.
with me on this case.
Unmute, sir.
This is a case, in case somebody from Kurdistan watches, this is a Kurdish case, it's not my case, so I'm very grateful for the slides. It's a 28-year-old male, and you can see a 3 centimeter right renal pelvic stone, moderate hydronephrosis. Somebody previously attempted a URS on this stone, which probably in itself is not such a good idea, and put a JJ stent. And what would be the next step in the expert panel opinion? Can somebody comment on this?
Yeah, let us start from Harsh.
Yes, sir. So looking at the CT scan, it seems to be that the opposite side kidney has a very thin parenchyma left. So the first thing which comes to my mind that I'm dealing with a solitary functioning kidney here. As previous attempt to a DJ was done, but it has been failed, I guess. So straightway means if all the clinical parameters are normal and the creatinine is normal, I would like to plan a PCNL surgery for the same, sir, in a solitary functioning kidney.
Very balanced view. Yes, sir. Professor Noor.
Our only thing is anterior and posterior calyces are so much separated. With one puncture removing both, depends on the RGP, but anterior and posterior, there is some amount of gap in between that has to be kept in mind.
Well taken. Both the points are
I think we can, not to make it too long, I think we can all agree that this should be a PCNL, right?
Yes, sure.
Good.
Hello, hello?
Yes.
Yeah, we are listening to Professor Jivlet.
Yeah. So, Noor, just 1 second, please. You put a case that, you already know the answer. I mean, it's so easy for everybody to see this case. Okay, PCNL. It's,
Well, would you as the king of URS, would you do a URS on this?
absolutely. It's PCNL. I think it's the better choice. It's clear. But,
Okay.
not in all cases. Depends on the structure of the stone. Because I had such cases in 25 minutes, I realized a perfect flexible ureteroscopy in a stone, not hard stone. So not only the this image is important, but the structure of the stone. So I completely.
Yeah, I think we can safely say, since somebody attempted the URS and we can't see much impact of that, it is probably not such a soft stone.
Absolutely. And the second, I imagine that also not only in Dubai, but also in London, you had patient preference. So I mean, if a patient comes to you and said, "Okay, I like to tomorrow to go to to work, and I prefer 2 steps flexible ureteroscopy." What do you say?
Sir, important point is very
Go
clear.
somewhere else. Go to Romania.
The 2 points
Okay,
are
let's
very
go on.
clear.
Let's go on.
Yeah, it's a
Let's go
solitary
on.
kidney. It is a practically solitary kidney, and the stone appears very hard because Hounsfield units we can also see it's a very dense hard stone. So
Yeah.
there is a possibility it is not to do URS but to do a PCNL.
That's exactly
Yes,
that.
carry on, sir.
My first sentence was,
Yeah,
Okay, so let me go on with the case, please.
yeah.
So they did a spinal anesthesia. They took that double J stent out. They did a prone PCNL, punctured the lower posterior calyx. They noticed just a little oozing, which was tamponated by the Amplatz. It's a standard PCNL size 24, and they used a pneumatic lithotripsy. So far so good, and there is nothing abnormal about this case, right? Now, what they did notice though is that in relation to the bulk of the stone, they saw very few fragments in the kidney. And then they saw fragments outside the kidney alongside the Amplatz. And they finished the operation by inspecting the kidney, and it was stone-free. And then they went on and attempted to recover some of the fragments from outside the kidney, but they had eventually abandoned that. So what would be the next step in your opinion?
See, leave a nephrostomy inside. And secondly, if there is a lot of time has been spent working outside, leave a drain outside also. It's a solitary kidney for all practical purposes. The other kidney is not functioning well. So I will leave a nephrostomy as well as a double J stent. I will try to be very safe.
Well, that's very sound advice. Any other opinion?
Sir, I would like to also explain post-operative the relatives of the patient and the patient himself that there are some stone fragments which are outside the kidney which won't cause any harm to the patient, because post-operatively the patient might come back again with to me with an X-ray which can show some fragments in the region of the kidney. So to just decrease their apprehension about the same, I would like to go ahead and tell them firsthand that there are some fragments lying outside the kidney.
Okay, that's very, very true as well. Let me go on with the case. Now, they then decided to put an anterograde double J stent and a nephrostomy, but they found that very difficult. So they spent again some time trying to get into that kidney and putting the anterograde stent, and that didn't really work because the resident had retracted the safety guide wire into the lower ureter. So then they turned the patient into the lithotomy position, and they put a retrograde double J stent. So can the panel agree with that?
Yeah, some fragments might have gone into the ureter. Some fragments have gone outside, so maybe irrigation was too fast. or whatever, some fragments might have gone down into the ureter, which were not allowing the ureter this antegrade stenting. So now retrograde stenting has been done, fair enough. You could have done a ureteroscopy also from below to actually visualize if there are really some fragments there or not.
Yeah. So far, not a major problem, right? Everybody would agree what happened is more or less standard with a little bit of deviation, right? Hello?
Yeah, we are listening. Yes, agreed.
Agreed.
Okay.
We are eagerly waiting for next slide.
Okay. In the recovery, immediately after the operation, the patient had severe abdominal distension, very rigid abdomen, profuse sweating. Hemodynamically, he was, however, stable, no dyspnea. Well, then the toes started turning blue and he got an erection. So what is that?
It might be due to the extravasation of the fluid. There might be the stimulation of the sympathetic outflow chain in near the spinal region where you have entered the tract, and this has caused an extraordinary sympathetic outflow, which has caused him this symptoms.
See, there are many possibilities, but you have gone through the lower calyx. So, in lower calyx and on the right, it was right side. No, yeah. So in the lower calyx, when you go through the lower pole, anterior to that there is colon, there is a retroperitoneal structures, and intraperitoneal perforation and intraperitoneal extravasation or ascites is not common through the lower pole. It is only through the upper pole when you go through and through. There is a peritoneum, and you can go directly into the ascites. You can go intraperitoneal. So whatever abdominal distension is occurring, it is maybe a colonic injury, maybe lot of fluid there which has not been drained. Rigid abdomen, maybe paralytic ileus because of this situation. Rest, this little bit of cyanosis and erection is pointing towards maybe some vascular thrombosis, some vascular changes have taken place.
Severe abdominal compression from a lot of extravasation. It should be rare. It should be picked up, but I suppose it can happen.
Oh,
well, I'm really glad. The expert panel deserves the name. So you are actually experts, from what I can hear, which is great. So the ultrasound shows a large amount of free fluid in the peritoneal cavity. So all the speakers before were on the right track, right? But it is intraperitoneal, although it was a lower pole access. I have seen this before in other cases where the amount of fluid was so high that actually the peritoneum was torn by the pressure. So we have that now. What is the next step?
This patient, I presume, is still on table, Noor. We are still on table.
Patient is in recovery.
Put the drain.
I think, yeah, you need an ultrasound guided drain.
That's correct. So we put a French 10 drain, and 2.5 liters of clear fluid was drained. The abdomen softened and the cyanosis resolved, as well as the erection. I didn't write that here. Okay.
Okay.
So then within 2 days, the creatinine, which was risen to 1.9, came down to 0.9, which is normal. Of course, the patient was initially polyuric and was also given some diuretics, of course. On the third postoperative day, he had mild dyspnea, but the aspiration of the pleura was dry. It was feared that part of the fluid would have gone into the pleura, but that was only, he developed an atelectasis. But he was then discharged in a good general condition on postoperative day 4. Now, this is the CT scans after. And if we increase that, so this is the situation 1 month after the operation. What now?
Still, there is some collection, I believe. This has been,
that's
all
yeah,
this has
that's
been, has been probably the collection
But it's
outside.
localized also, sir.
Yeah, it's now
Something
after 1
local.
month it will be localized. Needs drainage. It is a urinoma.
it's probably an old organized hematoma, so I wouldn't be worried about that. What about these stones?
Is the patient having a UTI or?
No, nothing.
Oh,
He's in a good general condition, renal function normalized, everything is fine.
I'll leave it.
Professor Bhaskar,
Yeah.
what will you do?
I think this is a non-contrast phase. If the patient is well, he's already had a lot. You might want to just clarify with the contrast phase CT. See actually, is it parenchymal? Is it now in the tract, or is there anything inside? As far as the collection is concerned, I mean, again, it depends on what the contrast CT shows. If it's a small connection and the patient is asymptomatic, you might just follow it up with another scan, because if it's just in the tract, you may not want to intervene and the patient is asymptomatic.
Remember when they did the nephroscopy at the end of the operation, the kidney was stone free. So I think we can safely say that these stones are in the tract and outside the kidney.
See, there has been a aggressive PCNL. You have come from posterior aspect and you have gone through and through anteriorly and then fluid collection into the peritoneum. So it has been an aggressive PCNL. And in the process, if there was some avulsion or there is some obstruction at PUJ, stenosis or anything developing, only then the urine will leak out. After 1 month and a urinoma will form. So I will try to identify by a contrast CT or by a RGP what is the status of pelvic ileal system, PUJ and ureter, why this urinoma is draining there. And then this needs to be drained. It has to be, it is a well organized.
Okay, that's all okay. None of this was done. Patient was absolutely fine. There was no sequela, no infections afterwards. The question for the audience, the learning point here is, do we have to do anything about these stones?
No.
Nothing, just observe.
Or just observation.
Now we have to
There's a point. There's a point made that the
outside
patient.
the system, so why bother at all? Just let it be there.
I think there's one good point raised that the
That's
patient
my
needs
approach
to
as well. Would the panel?
What about the collection? Whether we should
I
drain
agree with
that?
that, Noor, but there's one point that was raised, which is the patient should know that there are some stones outside. So every time he'll have an X-ray somewhere, they'll say, "Yeah, you've got stones." So
absolutely.
But what about collection, fluid?
Forget about that collection. That collection was left there and was resolved after some.
Sir, one RGP will keep me happy. Even a faint chance of connecting to that, if any chance some small stone obstructs, one RGP or a good contrast CT might say that, okay, that's closed, the calyx is closed, then we can leave the issue. Yeah. There should not be any connection. By chance, small also, it will open up later on. Foreign stone access.
I agree with that, but the kidney was also, you can see still in the bladder, there's the end of the double J stent, and somewhere down in the middle is a piece of double J stent visible. So the kidney was, of course, nicely drained with the double J stent all the time.
For removal of the stent.
Yeah, I agree with that. But the point I wanted to make is when the stones come out, don't do anything about it. Now, I've seen cases with ureteroscopy where stones come out, don't follow it. I've seen PCNL where stones come out, don't follow it. I've even seen a case, we are writing it up at the moment, where after kidney rupture, after ESWL, the stones came out of the kidney into the retroperitoneum. Don't do anything about it.
Just 1 second. We had such cases, but I think that it's important to inform the patient. Very important, because I saw.
Yes, we said that already.
Absolutely. I saw ureteroscopy for so-called ureteral stones that were out of the ureter. I saw such cases because the patient doesn't know, you know.
Absolutely, absolutely, yes.
Yes, I have one comment. Yes, I agree with you when the stones are outside the kidney, but they are lateral to the kidney. But we have to do our best to prevent this. This is a large stone burden outside, so I don't understand how it happens. So we have to prevent it. And also, especially in the, and I think we have to do our best to remove it. But if we cannot, we cannot. But especially if in the middle, medially to the kidney and near the UPG or the pelvis, I have seen some case with the UPG stenosis with compression, inflammation, and compression from the outside. So we have to do our best to remove all the stones that are medial to the kidney.
Yeah, the problem is if you, like our colleagues here, when they tried, of course, to retrieve these stones, they did that for an extended period of time and filled the patient with 3 liters of water, which is not the ideal case.
Someone from the audience has confusion whether it's an infection stone and there will be sepsis. How the patient behaves.
Well, if that would be the case, then you might, if you get infection, then you might have a case. Of course, if there's an abscess, you might have to remove it, but that's a very rare.
No, this,
I mean, the complication is already very rare, and infection of these stones is even rarer.
This problem of stone going out either in the PCNL or during the URS is not something which is very rare. And the advice and the standard teaching is just leave alone. Don't try to go outside the ureter or outside the kidney to extract those stones, which will cause more problem. So whatever stones which are gone outside, most of the time they remain silent and nothing happens.
See, I am only worried about the collection because sometimes you have seen this getting infected later on. And if it is a large hematoma, organized clots, they will not come out easily. So what I do is to pass 2 implant sheath of 30 French into that. From one side, you pass the irrigation fluid, and from the other side, you suck off. Only then you can remove all this hematoma, organized hematoma, and maybe infected material if it gets infected, which is quite common in India. Yes, sir. Next, what happened? Professor Noor.
Yes. Oh, sorry. I had to wake up.
Yeah, we have taken 4 hours. Yeah.
We have, Paul, you have extended by 2 hours.
No, over.
Audience, sir, there, sir.
Over to Chandramohan. Yeah.
Yes, sir. Sir, Noor, sir, you really made interesting. I got personal message. Next time, if you conduct, please conduct like this and a question-based than lecture-based. You really made interesting. Only thing is that please give long-term follow-up. I hope that patient doesn't require any more intervention till he leaves. Thank you, sir. Really interesting.
No, he didn't. I mean that case is about 3 years old, and the patient is absolutely fine.
Great, sir. Sometimes patient may fight. Escape all, sir. With your permission, it is time Saturday evening. Even my wife is also calling. What happened? She is not watching. So we will take your permission. 5 to 10 minutes. We will take the questions. You conduct the see the questions and conduct, sir. I have seen some questions. I will ask you. You conduct the. Or should we?
No, you ask the questions because I have not seen the questions. But before I would like to thank all, and I'm really not great. I'm not only thankful, I am grateful to all the speakers who are there with us, their enthusiasm of teaching, and to everybody who has participated, audience, everyone to be here with us. So over to Chandramohan. Yeah, whatever questions you are putting, we will
ask one question each. First question I asked is during COVID time. I asked Bhaskar sir. I just want to reconfirm if you are comfortable with PCNL versus RIRS both. Straight away, I am asking which one you choose.
I choose the one you like. I will choose the one you like most, Chandramohan. which will be RIRS.
Yes, sir. Okay. The second question goes to SK Paul, sir. Sir, have you ever faced in your career that during PCNL you have to stop and open any time? Have you opened, whether you have done by you or done by others? Have you any time opened while during PCNL? How it will be in the intraoperative scenario?
No, touch wood, not opened immediately, but one of the cases way back in '92 when this embolization was not available in nearby hospital, neither in our hospital. So one patient who had secondary hemorrhage, myself and the operating surgeon who had done the PCNL, both of us combined together and we opened up the case. It was a hell. It was so much of blood clot, and so much means every time there was a desire to remove the kidney, do nephrectomy. But ultimately, after removing all the clots and all collection, when we reached up to the kidney, it was looking very innocent kidney, sitting silently, no bleeding. So we
That's what I want
just
to know, sir.
so we just closed it and came out. After 2 days, he started bleeding again. So after 2 days, we had to do nephrectomy. This is the only one case
Oh my
where
God.
open surgery was done.
Sir, I have a question to submit, sir. When you are doing microperk in a little dilated system, stone moves here and there. In those cases, will you put a guide wire and redo dilatation to a bigger size and finish the case?
Yes, because microperk, if the stone goes and it is not coming under vision, you have to change to mini PCNL. There is no question about it.
Okay, sir. Harshavardhan,
Yes,
you,
sir.
you have shown always you are crazy of the cobra catheter. Do you think that the same thing can be done by a thicker guide wire? Like SK Pulsar uses the J-tip guide wire with a thick backside. Many a times, I don't know, still he will be using, many of the surgeons use Terumo guide wire. If you have given choice, which guide wire is better not to lose the track, in your opinion? I know you are, I mean, you are doing a lot of PCNLs. What is your opinion?
Right, sir. So we can use both the glide wire and a guide wire as a Teramo guide wire. The only disadvantage with a green colored Teramo guide wire is that it doesn't have that pliability and it's not that flexible. So in case if there is a step in the dilatation, then it gets bent. And then the trouble starts for the further dilatations. So in my point of view, using a glide wire is way better than using a Teramo wire. Sir.
SK Pal, sir, you have to say better. SK Pal, sir.
Terumo
Which
guide wire
guide
is
wire
so
you use routinely in your PCNL theater?
a J-tip guide wire, which is a stainless steel this Teflon coated guide wire. Angiographic guide wire is used by me because Terumo guide wire is so slippery. When you need it most, it will slip out.
Okay.
Half your attention is only on saving the guide wire. It should not come out.
Thank you, sir. Dr. Dong, you have listened the Hermi who was attacking talk on prone versus supine. I just want to ask Dr. Dong, in supine PCNL, water drains out immediately. It won't stay back. Does it appear the things like more bleeding? Do you have, I mean, what is your experience? By chance, if the water is not staying, it is coming out quickly, it appears as if it is bleeding more. Is there any relevance in that?
So if still bleeding, and you can see anything, right?
Yeah. In supine PCNL, does it appear more red because the water is not staying?
Okay. I think just stop and terminate. Just stop and leave the first minute or just terminate it. Just stop it. If you can see anything, safety first.
I just want to ask Hermi,
Yes,
if you go with mini nephroscope, is it easy to go from inferior calyx to ureter in supine versus prone? What is your opinion? In which case you can go easily into the upper ureter?
If it's a supine using a mini PCNL,
yeah.
Well, it depends on the location of the stone. If it's the location of the stone is in the ureter proximal part, maybe I will try to use also the middle calyx.
even in supine, it's accessible. I have learned from my mentors how to bring down the kidney, and so that you can actually get into the middle calyx. So it's easier for you to look down the ureter.
Is there any difference between supine or prone, or if you are going from the inferior calyx? What I mean to ask.
Okay. Well, not really, not so much, because the inferior calyx is the easiest calyx to access. You can hit it straight to the calyx. So whether it's supine or inferior, that's why whenever I'm still choosing the supine patients that I'm doing. No, these are the pelvic, inferior, partial staghorns, but not much difference.
Professor Lezurek.
Yes.
After doing how many PCNLs, your residents, you feel that they are confident to go outside and practice? What is your clinical judgment in the theater? Some learn fast. Some people will be asking always which calyx, which calyx. Is there any difference you observe in the residents?
Yes, of course. That's why we had developed these models for, simulators on gloves for learning. So, we try to teach them to try to analyze the radiology images that we have, and also to do this 3D, intellectual 3D visualization in space. So this is one of the first exercises that we do before every procedure. And I think it helps a lot to do this imaging to learn fast.
Same question I want to ask Sabni sir, because you are running the institute. How do you feel that resident by final year, what is your impression that what makes them 100% good in doing PCNL safely?
So the question is that it is just the volume which is very, very important. Before, in fact, they start doing it, they assess so many cases, they see so many things which have been done by different people. So automatically they pick up, and by the mid of second year, they start puncturing themselves, and by third year, they are almost confident of doing PCNL.
Okay, sir. Sir, last question to SK Pal, sir. I have seen 5 years back, you used to defend for all the mini perk. You put nicely because your initial puncture is most often very, very scientific, because you do that puncture in 30 degree and then come to 0 degree. That is your favorite point of discussion. Even today, if you have a more than 3 centimeter stone, do you recommend, you have laser, you have lithotripter, you have all scopes, do you go for 30 French sheath, or you changed your mind?
No, it is the availability of instruments. Now smaller nephroscopes are available. Therefore, if I have a 19 French nephroscope which I have bought. So now I usually do either 22 or 24 French.
This 19 French, which companies, sir? No conflicts of interest. Is there any 0 degree, 5 degree view? In that point, I'm asking.
No, this is from stores only, that they're with sheath and without sheath. Yeah. You can use that. And earlier when we were doing that time, nephroscope were 24 and 27. So we had to go to 30 French.
So is it the metal sheath or the hook sheath which is more comfortable for you, sir?
All are same. All are same. There is hardly any difference.
The movement of the scope.
All are same. You just get used to it. 0 degree, 6 degree, 15 degree remains the same. Recently, one company had introduced 30 degree nephroscope. To that, when they gave it to me for just initial assessment, I straightway told them, no, it is not good, because I am going in an undilated system also. I have to see up to see actually down. I have to take the instrument like this to see 30 degree down. So it should not be more than 10 degrees angle, 0 to 10.
So with that, I want to close the session.